Sorry, these are the topics that I'll pass on my presentation. I'll talk about a little bit what was our past, what we learned from it, and then the prospective study we conducted since 2015. We know that liver cancer, although all the advances in systemic treatments, surgical procedures, anesthesia, all that, has a rise in incidence, but also morbidity and mortality. And so, primarily, liver malignancies are a therapeutic challenge. We start doing a retrospective view of what we did until 2014 with many works and many publications, and we learned something from our patients. We know about HCC that microvascular invasion in our patients was a predominant factor even in multivariate analysis. We know also that size would matter in these patients, and when you compare size and microvascular invasion, the difference was higher. In the subgroup of patients that we transplanted by HCC, the difference was also seen due to microvascular invasion. And we saw that a quarter of the patient had a single lesion, only 10% as a single less than 3 centimeters, and about a quarter was within the million criteria. In respect to cholangiocarcinoma, we studied also in our patients what were the factors that had impact in survival. And nodal invasion, as also vascular invasion, were the higher ones. We know that for HCC in the diagnosis algorithm, when you can mark the HCC with an exam, imaging exam, no biopsy is needed. But nowadays, with the prognostic biomarkers that there are, tissue is demanded. And this can have implications in what we are doing. So, in the late of 2014, we start thinking where and how we could improve. We have an hospital that is side by side to our Faculty of Medicine, where we develop our investigation. And we start to try to stratify our patients, our HCC patients, for example, in a classification that could be reproducible to our prospective study. So we conducted a review of patients submitted to surgical treatment, partial hepatectomy, or liver transplantation with pathologic diagnosis of HCC for a 9 period. And we reached the classification of Tsujiwaka that subdivided HCC in 3 subtypes by doing a 6-panel immunohistochemistry in tumors. And what we saw is that the group with biliary stem cell group was worse than the others group. Although we could validate in our population a risk stratification classification for HCC. After this, we conducted a clinical study of patients submitted to resection or transplant for HCC and CC. We did, and we are doing, an extensive review and registry of all data. And we are collecting samples from tumoral, peritumoral, non-tumoral, and blood samples of these patients. Initially, we start to conduct a 2-arm study in genetic and molecular characterization, and other one in immunological analysis. Regarding genetics, we know that in the carcinogenesis process, there are alterations in genetics and epigenetics. And you have hyperactivation of oncogenes, and you have suppression of tumoral suppressor genes. We analyzed within 2 techniques, by array CHG and MSMLPA, and we start studying in the different tumors where we have a deviation on the left side, meaning a deletion, or on the right side, and meaning a duplication. And then, with the hybridization with probes, known probes of oncogenes and suppressor genes, tumoral genes, we developed a genomic predictive model of patients with cholangio and hepatocellular carcinoma. For instance, in patients with CC, extrahepatic CC, we start seeing a pattern that was common to all patients and a pattern that was present only with the patients with unfavorable prognosis. The same in the intrahepatic population group. And we were able to create a pattern within amplification or deletion in some pattern of genes that was a genetic signature for patients with cholangiocarcinoma, and even though for patients with worse prognosis in cholangiocarcinoma. In the MLPA, we studied the methylation, meaning the silence of some suppressor genes that could be a future perspective in therapeutic for these patients. Relatively to hepatocellular carcinoma, we did the same thing. We saw some patterns that were common to all patients, and we had also patterns meaning unfavorable prognosis too. Within the MLPA, we could see the methylation of some genes, and we were able to divide them in well-differentiated, mildly differentiated, and poorly differentiated HCC. In immuno-oncology, we want to study not also the general population of the lymphocytes that are invading the tumoral tissue and the crosstalk that exists between them, and we were also to study this subpopulation. We know that macrophages with polarization M1 are anti-tumoral by producing several factors, and on the other hand, you have M2 polarization that have a pro-tumoral activity by EL10. And so we were able to study our tumoral cells, and we were able to identify the subtypes of leukocytes that were invading and the crosstalk between the tumoral cells and the host cells. When we analyzed the whole family, we could see no differences. But when we analyzed, for instance, macrophages M2 that had on the surface this marker and this marker that are typical from M2, we could see that in patients with HCC were much higher than in patients with cholangiocarcinoma. The same for patients who have the PDL1 macrophages that are invading the tumor that were higher in patients with HCC than in CC. We are also able to study the tumoral cells to see if they presented also the ligand that this receptor will ligate. And so we were able also to demonstrate that in patients with worse grades of HCC had much higher quantity of leukocytes expressing the M2 polarization. So there was a related link between the amount of M2 and the grade of the tumor. We also analyzed indirectly the IL-10 that was produced for this M2, and we could see that in patients with macrophages M2 versus M1, the MRA was very higher for IL-10. And so we can say that in HCC, the infiltrating macrophages present higher expression of PDL1, indicating that we can study these macrophages, the tumoral cells, and the crosstalk between them, that we can select the patients that could benefit with this therapy. Then we passed to the liquid biopsy after purifying the macrophages that we identified in the tumoral cells, and we could see that the function of these macrophages are, even though the monocytes are altered in patients with cholangio and hepatocellular carcinoma. And this approach could be applied in clinical routine to evaluate innate and adaptive immunity and to monitor responses to different treatments. We reached our other point that The TNF-alpha that is purified from this macrophagous can play a potential role on the prognostic biomarker in patients with HCC with higher grade tumors. We also went to study the phospholipids in these patients, and as we collected samples before tumoral resection and after tumoral resection, and comparing them with healthy people, we could see that there was a very drastic alteration between the period, the pre-treatment, surgical treatment, and the period post-treatment. And this could guide us for subclinical relapse in these patients. And so, and from our recent investigation, we could say that the morphological criteria that we use for this patient are clearly insufficient to select the patients, that molecular and morphological classifications are emerging and have solid prognostic roles, so it's mandatory to introduce them in a diagnostic and staging tools, that within tissue can diagnose these patients. Through coagulation with clinical pathological data, it was possible to establish molecular profiles, which are molecular signatures of different tumor stages. The identification of the tumoral cells and the leukocyte that infiltrate the tumor cells may help to determine the prognosis of a tumor, and we could reach that higher infiltration of M2 macrophages in HCC is associated with worse prognosis. And so we can have new perspectives of treatment and new perspectives of individualized therapy. This is a work between our hospital, our university, other departments in other hospitals, in other universities, and I would like to thank all of the people that is involved in our investigation. And also I would like to remember Professor Krzysztof, that was my first director and also a former compagnon that has passed away recently. And I would like to thank Professor ZIENIEWICZ, that it's my director and the chief of the investigation. Thank you.
Thank you very much. The questions from the floor? Because we are still looking for the new weapons which can support the surgery and the other treatment of the HCC and CCC. The questions? Yes, please. Just on the microphone.
How you will change your approach or surgical approach, having those data? Is it going to change anything?
Thank you for the question. I think we can change all the strategies since the beginning. If I have a tumor, a patient that can be resected or transplanted with a tumor, and I know that when I have worse prognostic factors, patients do better with the liver transplantation. If I can, but the problem is that I only know what I have after the resection. So if I can choose, if I can know in advance what I'm having, I can choose the best treatment, surgical treatment for the best patient. On the other hand, with these techniques, we can also study the molecular profiles that we can blockade with the new pharmacs that are emerging. So what we can do and what we have to do is to analyze the tumoral tissue and the immune system of the patient and analyze the crosstalk between both of them.
Okay, thank you, Ricardo, for your presentation. Just one question. Do you think you are giving us a prognostic tool after resection? Do you think it is possible to gather this information as a liquid biopsy in order to predict the future of the patients?
That's the golden point, I think. So that's where everywhere wants to be. What I've showed with the work that we are doing with, for example, the TNF-alpha, the serum phospholipids, it's where we are trying to make parallelisms of what you know after resection and what the patient gives you, because we are collecting samples before the resection, and we are comparing it. We have some data, our very preliminary data. This is ongoing, but I think that is the future. We will know previously to the surgical treatment what we have, or at least a good idea.
That would probably be included in artificial intelligence and e-learning, right? So
yes.
Because there's so many data, we are a little bit confused because since many years we hear all this different signature, but at the end of the day, even for HCC, we don't have much that has a practical consequence today. And now the e-learning integrate that with many other radiology features, maybe something will come in the future.
Thank you for your comment. That's the very true. We are working also with the science and technology part in the university that are doing since the beginning all the work of gathering together all the millions of data we got and trying to get patterns. We are looking for patterns of good prognosis, intermediate prognosis, and poor prognosis. This is what we are trying to get.
Why this need to be published so people can use it also with other criteria. Okay, thank you very much.
Thank you very much.
Thank you very much.